Hello and a warm welcome to today's Speak Out session. Whether you're joining us live or watching at a later time, we are so glad to have you with us. My name is 𝗥𝗲𝘀𝗽𝗶𝗿 and I'm part of the communications team at 𝗟𝗶𝘀𝗃, the European Foundation for the Care of Newborn Infants. I'll be your moderator today for the important discussion we plan to have. This Speak Out session is taking place under the umbrella of the European Standards of Care for Newborn Health. An interdisciplinary European collaboration dedicated to developing and updating standards of care for key topics in newborn health. The European Standards of Care for Newborn Health bring together healthcare professionals, patient and parent representatives, and industry specialists from across Europe to ensure that every baby, no matter where, when, or how they're born, has access to the highest standards of care. We are here today to talk about RSV, respiratory syncytial virus, a common and highly contagious respiratory virus that primarily infects the lungs and airways. While it typically causes mild cold-like symptoms, RSV can take a more severe course, particularly in older adults and infants, leading to serious complications. In fact, RSV is the leading cause of hospitalization in infants. While preterm babies are among the high-risk populations, it is important to note that even full-term newborns can develop severe RSV, and it is difficult to predict which babies will be affected. Severe RSV can lead to long-term consequences such as recurrent wheezing during the first years of life. RSV is also the primary cause of bronchiolitis in children under 2, with cases traditionally peaking in the winter months, though we are now seeing numbers rise throughout the year. So we wanted to create this Speak Out session to bring together people from all sides, healthcare professionals who work hard to treat and prevent RSV, patient and parent organizations advocating for affected families, and of course, parents themselves who have experienced the challenge of caring for a child with RSV. So this format today is designed to offer more than just information. It's a platform for open dialogue, sharing experiences and learning from one another. So we want this to be a safe and supportive space where voices from different backgrounds and perspectives can come together to raise awareness, share stories, and hopefully bring us closer to better care and prevention for all babies at risk. Now, I'd like to introduce our speakers, each bringing their unique perspectives and expertise to today's discussion on RSV. First, we have Dina Hediger, founder of the parent organization Frühchen Schweiz, Preemies Switzerland, established in 2022. Dina Hediger is also the mother of preterm twins who faced an RSV infection at just 1.5 years old, with one of her children requiring intensive care. Both of her children received RSV prophylaxis during their first winter. Her experience as a parent navigating this illness will be invaluable during today's discussion. Next, we are joined by Assistant Professor Dr. Lindsay Broadbent, a lecturer in virology at the University of Surrey. Dr. Broadbent has over a decade of experience in studying respiratory virus host interactions with a particular focus on RSV and, more recently, SARS-CoV-2. Her research now looks at the long-term impacts of respiratory lung viruses on lung health. In addition to her scientific work, she has been deeply involved in public outreach, including over 800 media appearances during the COVID-19 pandemic and a TED Talk. Finally, we have Dr. Barbara Plak, a researcher at the Institute of General Practice and Public Health at the Provincial College for Health Professions Claudiana in Bolzano, Italy. She's also the mother of 2 children. Dr. Plak is a member of the expert group for the international study Rescue Family, which is conducted by 𝗟𝗶𝘀𝗃 and brings a unique combination of research and personal experience to our discussions today. We are grateful to have such a diverse panel of speakers, and we look forward to hearing their insights on RSV. Now, let me briefly outline how today's session will unfold. In the first part, we will hear from each of our speakers individually as they share their experiences and perspectives on RSV from their unique standpoints. This will give us a chance to understand RSV from multiple angles, both medical and personal. After that, we'll move into a group discussion with all of our speakers, where we'll explore today's key themes. This will also be an opportunity to discuss some of the broader challenges and potential solutions surrounding RSV care. We also encourage you, our audience, to engage with us throughout the session. Please feel free to post your questions, feedback, and comments underneath the live stream in the comment sections of your platform. We'll be keeping an eye on them, and we'll do our best to bring your questions into the conversation. So let's keep the dialogue open and interactive. Your input is incredibly valuable. With that, let's begin with our first presenter, 𝗫𝗏𝗫𝗏𝗫𝗏. 𝗫𝗏𝗫𝗫𝗫 is not only the founder of Frühchen Schweiz, Preemies Switzerland, but also a mother who has personally faced the challenges of RSV when her preterm twins were affected by the virus. One of her children even required intensive care during the illness. She will share her story and insights as both a parent and advocate for preterm infants. Dina, thank you for being here, and over to you.
Thank you for the introduction and for the possibility to be here. I'm very happy to be here today and to share my perspective on those affected families. Our twins were born in 2018 at 26 weeks of pregnancy. They spent over 100 days in the NICU. We were briefly informed orally about RSV during our time in the NICU, and that we need to be careful and that there is a possible vaccination for that. After our discharge from the NICU, we asked our pediatrician if we could vaccinate the children against RSV. We had to submit a request here in Switzerland with the pediatrician to obtain the coverage for the coasts, and so on, we received the vaccination for our kids. Unfortunately, they were not unable to vaccinate the children in the second winter, as the costs were no longer covered and the pediatrician also advised against it. So we decided as parents not to proceed because they were a little bit bigger and 1 year old already. At the end of this second winter, one day they started to getting sick, a little bit of fever, runny nose, a little bit of coughing. And after a few days, we went with them to the doctor. He tested them RSV positive. For us, it was a shock, but we were still quiet because they were okay. And the O2 level were around 93, so totally fine for preterm kids with RSV. And on Friday, we took them one time more to the doctor before the weekend, and they were still stable and okay. Also, the mood was okay of them. As you can see here on the picture, they looked a bit weaker with each passing day at home. And at the weekend, so on Saturday, everything turned. One of the twins wasn't playing as much as before and seemed very tired. We measured his O2 level with the healthcare professionals and it was 86. So we rushed to the hospital, and the other twin had still a O2 level around 92, 93, so he could stay at home. And 2 days later, when I was there with twin B, the twin A at home the grandfather was taking care of him because my husband had to go to work and I was in the hospital with one of the twins. And he was totally okay in the hospital. As you see, he had some oxygen, but it was okay. And when the grandfather told me at the phone that the twin at home was just sleeping the whole day, I had a bad feeling about it. So I told him that he has to come to the hospital with him too. And we measured the O2 of him and it was 76. And they tried to give him some oxygen, but it was very difficult. He was moved to the intensive care, as you can see the picture down on the right side. And for us, it was a very shock situation because we were back there where we started the time as a family. And on top, on the RSV, he had developed a lung infection. He was very, very sick this night, and he had to stay there in the intensive care for 1 night. And they started with antibiotics. We were able to stay at the hospital 24/7 And it was also for me a very good feeling that I can be there with my kids. My husband had to work, so all of our family members came to help me out with our twins in the hospital. By the end of our time in the hospital, it was a little bit hard to spend an entire day in such a small room, because they started to feel better and they had much more energy again. And as you can see here in the picture, they felt also a little bit better because of our dream doctors we have in Switzerland, and they started to eat again. And we were also lucky that it went well. So in total, twin B was in the hospital for 10 days and twin A for 7 days. For the parents, it is important to have more information about RSV during the NICU with some fact sheets, because we never received any of these fact sheets during our time in the NICU. And I think also it helps a lot to hear some stories from affected parents, and of course to receive this RSV prophylaxis for 2 winters and not just for the first winter. For the preterm and sick newborns. And in Switzerland, we are very lucky since October, since this month, this year, now all babies receive an RSV vaccination, and the preterm and sick babies also the second winter. So we are very happy about this situation here in Switzerland. Thank you for listening. And I'm hand over to Barbara back, or I don't know who.
Yeah, thanks a lot to Dina Hediger for sharing your very personal journey and the challenges you faced as a mother of preterm twins. I think your story truly highlights the impact RSV can have on families. Now we turn to Assistant Professor Dr. Lindsay Broadbent, a virologist and expert in respiratory viruses. Dr. Broadbent has spent over a decade researching RSV and the longer-term effects it can have on infants' lung health. So she will offer us a scientific perspective on the virus and what we know about its behavior. So, Lindsay, we're looking forward to your insights, and over to you.
Thank you. So this is a slightly more different tone of talk. Really, we're going to focus on the science behind RSV. What it is, what it does, and why it causes disease among infants and older adults, of course, as well. And Annika gave a fantastic overview at the start of the session about what RSV is. You know, it is a seasonal respiratory virus, and in our climate, really, that means the winter. So we start to see cases increase around October time, and we see cases increase really throughout winter till around February, when they start to decrease again. And RSV causes around 33 million infections worldwide every year. And I will stress the majority of these infections are incredibly mild. However, about 10% of these infections, which is roughly 3.2 million infections, result in a hospitalisation. And the majority of this hospitalisation is actually in children that are less than 6 months of age. So this really is a disease of very, very young, very sensitive, very vulnerable children that have a very immature immune system. And really, of all these infections every year, there are around 160,000 deaths. The majority of these deaths are in lower middle income countries, where the supportive care is just harder to access. However, we do see deaths in higher income countries where we hope that we would not. And we are still trying to limit that, and of course, limit the number of hospitalizations that we see. It is, of course, the most common cause of lower respiratory tract infection in children under 1. And one of the reasons for that, from you see in this diagram, is because of the immature immune system. So when children are born, they have maternal antibodies. So during pregnancy, the mother passes antibodies on to the child during pregnancy, and that then gives that child some form of protection against common bugs, against common infections, including RSV. However, those maternal antibodies don't last for that long, and about a month after birth, they really start to decline quite significantly. And at that age of about 6 weeks, the child's immune response is still incredibly immature. And that is when the risk of severe RSV disease is at its greatest. So really between 6 weeks and 6 months of age is when children are most likely to suffer severe RSV disease. Now, we get partial immunity from RSV throughout our life, but we can continue to be infected at any age, really. So adults also get RSV. If we're fairly young and fairly healthy, this results in a common cold. But as we age, our immune system then starts to decline. And when we hit kind of 70, 75, our immune system again starts to struggle. And that is when we can be at risk again of severe RSV infection. So not only do we focus on really the children, but it's also being recognized as a pathogen and a virus that can really cause a lot of disease in older individuals. Now, we're going to obviously focus on the children here, and there are a lot of factors that contribute to severe infection and severe disease. And I will say that a lot of this is correlation. We haven't yet figured out the reason why some children get very, very severe disease and end up in hospital and other children do not. But we certainly know a lot of the factors that contribute to it. Things, for example, as we've said, about being younger, about being less than 6 months, being born preterm. Again, that has an impact on the child's immune system and how mature their immune system is. We also see things like viral co-infections, medical comorbidities like lung disease or heart disease. They also contribute to this probability of developing severe RSV infection. There are, though, on the other hand, things we can do to try and reduce the severity of infection. As we've just heard from Dina, things like that prophylaxis, being offered the monoclonal antibody for those children. We'll talk a little bit more as well about RSV vaccines now that those have recently been licensed. But there are also other things we can do. And this is quite bizarre, really, but it is true that there are indirect immune consequences of things like the BCG vaccine and the measles vaccine. They can improve our protection against other pathogens like RSV as well. We also really, really want to delay the age at which children get their first RSV infection, and that's incredibly important. If we can prevent children younger than 6 months getting RSV, then we can hopefully reduce the number of severe infections and how many hospitalizations we see from that. So I've already touched slightly on prevention and treatment, but really just to highlight this, we now do have vaccines that are licensed. Certainly in the UK, where I am, we have a vaccine that's licensed for older adults, but also for the administration to pregnant women. So this is given from 28 weeks of pregnancy and beyond. And this helps to really boost those antibodies, those maternal antibodies that are passed to that child, to lengthen the time that that child is protected post-birth from severe RSV infection. We also then have, as we've heard just in Dina's talk, these prophylaxis methods, and these are monoclonal antibodies. So we have palivizumab, which has been licensed for quite a long time, and then recently the development of 𝗟𝗏𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗁 which is a great drug. And it is the second generation of monoclonal antibody. And this one is fantastic because it really only requires one injection to protect the child for the full season, for the full winter season. So it really has revolutionized a lot of kind of protection against severe RSV. Now, in terms of treatment, unfortunately, we are still incredibly limited with the treatment options for RSV. Primarily, it is supportive care. We mean keeping children comfortable, making sure they have fluids, making sure they can breathe properly if they need access to oxygen. It really is very much supportive care. And there is still a lot of research into this area to improve treatment options for RSV. So that's really what we do when someone has an RSV infection, but we also need to think about the follow-up. What happens after someone has recovered from RSV? Are there still health implications? What does that mean for the child's future lung health? And there's a lot of focus on this at the minute. And this is certainly an area that I'm particularly interested in. And one of the reasons for this is that recent research has shown that both the number of infection, the age of infection, and the severity of respiratory infection actually can determine our lung health when we're in later life. So we have more of a risk of dying prematurely from lung disease if we have severe respiratory infection when we're a very, very young child. And I will stress that this is the minority of people. The vast majority of people make a full recovery. But this is incredibly important because not only do we need to be aware of the fact that what happens in our early life can dictate our lung health throughout life and through older age, we can use this to try and target and understand why some people get very sick and others don't. This also comes into play when we're discussing asthma as well. Childhood asthma is 3 times greater in children that have been hospitalised for RSV in early life than those that haven't. And this is not a cause and effect type story. We don't know if RSV is the cause of asthma or if those children are just genetically predetermined to suffer from poor lung health. So they suffer severe RSV disease and they suffer severe asthma. But there certainly is a link there that a lot more research is being done to decipher. And I really want to focus on that and about the ongoing and future research. We are definitely focusing still on vaccines, preventions and treatments, improving the ones that are licensed, making sure that we have coverage not only for pregnant women, but for young children, for infants and throughout life. We are also looking at why some children get severely ill and others do not. There seems to be potentially a genetic factor. Is it about other bugs that are infecting children? We're not sure. But we can definitely learn a lot from this. And we can also learn a lot from those children that have severe RSV infection and do not develop asthma. We can look for them to the answer about potentially how to prevent asthma in the children that do have severe RSV. And I think importantly as well, we need to focus on the fact that RSV is a virus that mostly impacts young children, but that impact is just not immediate and acute infection and disease, that early life RSV infection can have long-term consequences. And we really need to take RSV as a severe disease and not just a common cold. So overall, we certainly need more research. We need a lot more awareness around what RSV is and the consequences of infection, and we need to be aware of it and the impact of it on our early life of health and our really our lifelong health. That's where I'm going to leave it. Thank you. I appreciate the opportunity to talk and happy to answer any questions.
All right, yeah, thank you, Dr. Broadbent, for shedding light on the science behind RSV and its impact on infant and child health. I think your expertise provides us with a vital understanding of the virus from a medical and research standpoint. Next, we'll hear from Dr. Barbara Plack, who brings both a personal and professional perspective to this discussion. As a mother of 2 and a researcher at in Bolzano, Italy, Dr. Plack has seen RSV's effects both in her family and in her work. She'll share her experience and discuss the broader challenges families face when dealing with RSV. Barbara, thank you for joining us, and over to you.
Thank you very much. Should work. Let's see. Can you see it? Can you see the screen?
To try.
Okay. Is it working? Yes.
The first one.
So I can see it. Can you see it too?
Yes, you're good.
Okay. So let me talk about how you can get RSV. So now that's very simple. If you got 2 children at home, 2 little children like I did in 2021. So basically, we had back then a 4-year-old boy and a 3-week-old girl. Now, she was delivered full term. She was healthy. and she got no vaccine. Why? Because she was not at risk, so she had no access to the vaccine. So in Italy, babies still don't have access to the vaccination. Now with November, some regions start to actually vaccinate babies. Now, back then, I was already fully aware and informed about RSV because I'm a lecturer here at the University for Preventive Medicine. So we knew about the problems, we knew about the challenges, and we kept the older child at home for safety reasons during birth and the first 2 weeks. But as we were in 2021, he already stayed at home far too long because of lockdowns. And whoever stayed at home with a 4-year-old boy knows that it's not good for him if he's isolated so long from other children. So what we actually did was we sent him back to kindergarten because of mental health considerations. We did that, and well, a few days later, he became ill. Now, knowing what happens, we actually were pretty hardliner. We started to do a strict isolation. So we separated father and son from me and the daughter. They, ate in separate rooms. The father interacted with the baby only when he had a mask on, and the boy, actually, so the brother, was never there when the baby was present. So we really, really kept them away from each other. We tried to focus on repeated hand washing with the little one, so with the 4-year-old, and really tried also to disinfect frequently the surfaces. But despite all efforts, the baby still contracted RSV. Now, why is that? Because obviously it is almost impossible to implement the prevention guidelines in a multi-child family. So if they don't provide you with a nanny and a separate apartment, it is quite impossible to do or to protect a newborn, a baby, if the brother or the sister, any sibling, has it. Also, we have to say that in Italy, for example, and this is a problem in gender medicine, the care burden is usually only onto mothers, and the father has no right to stay at home if the sibling is sick, if the mother is at home with a newborn. So we really got a lot of problems there, and we're not able to protect our baby from getting RSV, even though we were fully aware of the virus. We really had actually the privilege of knowing all the preventive measures, and we also tried to implement them. So whose fault is it that my baby got RSV? Is it my fault? Obviously, it isn't. Parents are very often blamed for failing to prevent transmission. That's what we call victim blaming, and it's very much stigmatizing. And it's quite ridiculous when we talk about infectious diseases, as we just heard, and a disease that people get once or even twice a year, and then we put the whole responsibility into the private sphere on families, especially on mothers when it comes to newborns, and say, well, that's your fault. You did not look after them in a way you should. But obviously, preventive measures are not transferable into real-world complexities if you really put them like that. Like it's your fault. It's your responsibility, because a preventive strategy, obviously, when it comes to an infectious disease that places the entire burden on a family, is obviously bound to fail. So what we actually need is a collective societal effort to protect the children. Now, what we really have to do, and I see that as a mother, but also as a researcher in the area of public health, we really have to recognize that RSV is a serious public health threat, and this includes, and it has to be included in a broader infection control strategy. For COVID-19, for example, people were very much informed, and nobody would ask, well, you got COVID, so is that your fault? Why didn't you look after yourself better? But it's rather the question of, okay, how can we try that the transmission decreases? And we have to understand that we all have to work together in order to reduce the transmission. So what we have to do is really we have to look after, we have to see that there is a shift from the family-centered view and responsibility to more collective measures. what could these collective measures be? So, for example, what we really need is support from daycare and schools. So we, for example, didn't know that any other child in the kindergarten had RSV. So if there are small group childcare options, that's obviously better, especially if there is a high-risk child or newborn at home. Our son was in a group with 30 children back then. And obviously also alternative care options would be very good when the older sibling is sick, because how are you supposed to do that if you are a mother of 2 or 3 and you have one child at home who has RSV? How are you supposed to care for them, which is your responsibility, but also, you know, make sure that that one of them or another one doesn't get sick. And what we also should do is that we should encourage other parents that they keep their sick children at home, and obviously also without penalty, because, for example, in Italy, if you send your child to the kindergarten, or if you don't send it to the kita, to the 𝗕𝗿𝘀𝗀𝗃, you have to pay anyway. So we also need community awareness that actually goes beyond only focusing on families, but for all age groups. Also because RSV obviously is not only bad for very small children, but also for elderly. We need a clear RSV monitoring and reporting, because that's what we do with infectious diseases. We have to increase testing. We have to, you know, increase the communication with parents, and we have to have more transparent reporting on current infection waves. And also, obviously, you have to strengthen mental health support. We have to stop victim blaming, and we have to stop putting unrealistic expectations on families. Having said all this, this doesn't mean, obviously, that you should not follow hygiene rules, because they obviously work and they are important. But it's also important to put a realistic view on families with more children, because what happens otherwise is what we call a backfire effect. If you do everything you can and you still get the problem, the disease, and everybody tells you it's your fault, next time you don't do anything anymore, because why should I follow hygiene rules if they don't work at all? So what we really have to do is put it into perspective, into realistic expectations, because that is very important. And as a mother of a child who now, as we can see in the picture, just turned 3 on last Friday, it's very important that we just stop victim blaming families if a child gets RSV, but we support these families, because for us, obviously, as also for Dina and for all the other parents affected, this is such an incredibly scaring and frightening experience. So I would leave it with that, and I am happy to hear or to get some questions. Thanks a lot.
Yes, thank you, Dr. Hlack, for sharing your insights and your personal experience with RSV. I think it's clear that both research and lived experience are essential in understanding the full impact of this virus on families and healthcare systems alike. And also, thank you for emphasizing that families should not bear the burden of RSV alone, and that responsibility must shift to society and the healthcare systems as a whole to find effective solutions. Now we'll move into our open discussion. I'll start with a few questions for our panel to explore some of the key themes we've heard today, and we'll also be bringing in questions from our audience. So yeah, let's dive deeper into this important topic. And I would like to start off with a question that's, I think, for Dina and Barbara, which is, since you've both experienced what it is like to have a child sick with or from RSV, I was wondering what forms of support would you have wished for as affected parents at the time? What would have helped? Maybe we start with Dina, and then Barbara, you can add on.
For me, it would be helpful to have both twins in the hospital. Also, if the other was not that sick at the moment, at the beginning. But I think we could help him much earlier, and he would not end maybe in the intensive care, because they would help him earlier. Yeah, I think this with twins it can be very helpful if you can take both, if they are infected both.
Yeah, well, for me, the biggest problem was that, are you finished, Dina? Is it okay? So for me, the biggest problem was that everything that has been learned throughout the last decades in order how you treat parents when they have a child in the intensive care unit was just abolished. So it didn't apply anymore because it was 2021. So it was time of COVID, and it was really, really terrible because I was separated from my daughter. And as I told you before, she was a full-term baby. She was healthy. So she was 24/7 with me. And all of a sudden they ripped her away, brought her in the intensive unit, and I wasn't allowed to see her but for 1.5 hours per day. And it was really crazy. I had to be in the car. It was November. It was so cold, and I pumped my milk in the car because I didn't even have a room where I could pump the milk. So like really, what was back then the biggest problem for me was the isolation. I couldn't see my baby, and everything that we know is very important for parents when their babies are in intensive care unit was just not applying to us. And another fact was also that, so I was never offered any support, any psychological support or anything, or just, talking with somebody. And that was also because what I noticed was that RSV babies usually don't stay long at the intensive care unit. So some few days. So my baby stayed there 3 days. I think he said a week, 10 days. And they really focused very much on the parents with the babies that stayed there longer. They got also the support and the psychological help, and we didn't. So we were so RSV babies and mothers and fathers were left outside alone. So what I would have needed was spending time with my baby, getting all the treatment also other mothers and fathers got when their babies were there. And and also what helped for me was, for example, when the doctor said, you have a toddler at home or a kindergarten kid, a child, it's impossible to prevent the transmission because obviously you blame yourself. And hearing it from the doctors that it's really, really difficult or unrealistic, that really helped because obviously you blame yourself because you see your baby suffering and you always blame yourself. And it's really needed that you hear it from the professionals, even though you know it, but you really need to hear it. And besides, obviously, also all the information on what's going to happen now, are there long-term consequences, how can I maybe prevent that, what's, in terms of secondary prevention, we call secondary prevention, what can you do after you have a disease? Now, how could I strengthen the lung of my baby? What can I do now? For us, that was the biggest question because we were back to, now should we keep the older brother at home? What are we going to do? It's November. Now, what do we do until March? So really, actually, it was supporting and giving information. That's
okay.
What.
Yeah, thanks to both of you for sharing a bit more of your story. I mean, that is just very hard to hear. I wanted to use this and ask Lindsay if we can go into this one more time, because I mean, both your stories are very different regarding the children that had RSV. We have a preterm infant, or the twins that got it, and then we have a term-born child that had RSV and then ended in hospital. So I was wondering, Lindsay, can you maybe discuss a bit how does it happen? Why does RSV affect some infants more severely than others? And go into that a bit more in detail.
Yeah, it's a fantastic question, and really it is still the biggest unanswered question in RSV research. We know that preterm babies are at higher risk of severe disease. Their lungs are immature, their immune system is more immature, and therefore they cannot deal with the infection as well. However, with term babies, it's a lot more unknown as to why some children have very severe RSV infection. We think there may be a genetic element. We think there may be the microbiome, so your healthy bacteria that's in you, that may play a role. Environment as well may play a role. So if there are older children in the home that could bring viruses home from school, that may increase the risk. There are a lot of things that can contribute to that risk of severe RSV infection. But there is still a very large question mark. And I think there needs to be a lot more focus on this, a lot more research around this area. It's something that I think has baffled us. And again, as I said, we don't know if these children are just always going to get severe RSV infection. They just are unfortunately destined to have bad experiences with lung infections, or if something happens in early life. So if there is something that we can point to say, if we can stop this happening, then we could prevent that severe RSV infection. So yeah, an awful lot more research is needed in this area. And we also very much the research focuses on those children that have severe infection, but we need to look at the children that don't. We need to look at the children that are able to handle RSV infection as a common cold, and what sets them apart, and can we actually transfer that knowledge to other children and to help the immune systems of other children so that no one will experience severe RSV infection. But yeah, a lot of work still to be done in this area.
Okay, I think Barbara, you wanted to add something?
Yeah, I just wanted to add from a personal experience, and if there are any mothers or fathers listening, that my daughter since then never had any problems with neither with COVID. She got COVID, and now she, like, everybody's sick. She's never sick. Her brother always sick. She's never sick. She's quite a, resistant and a very strong little lady. So obviously that's one case, and obviously, it's not the case for everyone, but just, that, maybe for some others, this is also comforting to hear.
Yes, absolutely. And I think, that is, I think, the majority of experiences, that children make a fantastic recovery. And that is it, it is an acute infection. They recover and they live on childhood as normally and as healthy as anyone else. There is a very minor number of children, though, that will be more susceptible to subsequent infections. And we need to understand that as well. And we need to hopefully prevent those children from having subsequent infections, be it RSV, be it COVID, be it flu, whatever it may be. And we need to protect their lung health as best we can.
Absolutely.
All right, thanks. I have another question for Dina, because you as a parent, you experienced RSV firsthand, and I was wondering, what advice would you give to other parents on, I don't know, recognizing the early signs of RSV and how to go about seeking appropriate care, and maybe even sometimes fighting the healthcare system to receive some care?
Yeah, of course, my advice is to fight for the second winter, for the vaccination in the second winter. Luckily, here in Switzerland, we can have this now, but I think when I think back at our time, I should have fight more for this second vaccination, because they were still young, and they had a long story with their lungs at the beginning, because they were 6 weeks intubated in the NICU. So it was almost there to see that this will happen one day. And so I think this advice is very important.
All right, thanks. I would like to take up a question from the audience, because we also touched on this in the presentations a bit, that testing is also central to make sure we catch RSV infections or cases early on. But the question is, how can we have more testing implemented? I mean, some countries have better infrastructure than others. In some countries, the cold winter season lasts long and everybody has sort of a runny nose. How do we go about this to implement testing? Maybe Lindsay, you can start us off, and then Barbara and Dina can jump on.
Yeah, that's interesting. And I think actually in a lot of hospitals, if children are admitted with bronchiolitis, it's very often assumed to be RSV over the winter. So the children are kept kind of within the same ward, within the same area of the hospital, the bronchiolitis ward, but very often not tested for. It's just assumed, given the age of the children, given the symptoms, given the time of year, it's RSV. But I think wider community testing, so not just clinical testing, but wider community testing could help not only in awareness, But in certain circumstances, for example, not sending a child to nursery or daycare if they have RSV infection. So I would like to see kind of at-home point-of-care testing available. We know that these tests are now available. I think certainly in the States, you can buy them over the counter, and they test for RSV, flu, or COVID. But certainly they're a lot less common. Certainly in the UK, these types of tests are a lot less common. But yeah, I think there are certain roles for testing, right? And I think we've learned a lot from COVID. And I think rules around testing should really be about protecting other children that are vulnerable. So if you are potentially having symptoms, even as an adult, if you are someone that has a common cold, potentially you should be testing to find out if those symptoms are a common cold or RSV before you have contact with young children. And I think that really puts the responsibility, as Barbara has mentioned, not just on the family of young children, but on really anyone that has contact with someone that might be vulnerable to disease.
Yeah, I absolutely agree with Lindsay. There is not much more than I can say, but obviously, so testing all individuals in the general population, that may not be necessary or efficient, or even, it cannot do it, but it can be crucial in high-risk groups. So for infants, elderly, and so on and so forth, and in settings like hospitals, obviously, but also day care centers, nursing homes, and you should obviously always, it should be available to have a symptom-based testing, to have an outbreak management, and we need a better public health surveillance, because when you send your child to the kita or to the kindergarten, they always pin out everything, every little thing that is around there. I don't know how to say it in English now, like lies. How do you say whatever you have, every single stupid thing, but you don't know about RSV because nobody knows whether you have it or not. And if you happen to just have a newborn at home, and if you know that, you should know, okay, for now, ask Granny again whether she could spend time with the 4-year-old, but don't send him or her, because it's going to be very difficult for you to protect your baby from transmission. So we would need that. And also, as I said before, in terms of primary prevention before testing, also you make smaller daycare groups, because from my experience, maybe, I don't know, Lindsay, if you have other data, but from a public health perspective, it's really the families with more children that are more affected to get it, because obviously, in the kindergarten, they bring it home. So it's actually, we know the hotspots, we know really where we have the problems, and testing is always a difficult question, obviously. But back then, I really found it ridiculous, because the children at the kindergarten of my son, they all got tested like every week for COVID. They had to do that. But that was a problem for them, obviously. It is a problem, but it wasn't as big as RSV for the younger siblings of them, but they didn't test that. So it's really actually about targeting and tailoring. And that hasn't been done. At least in Italy, it's not done until now.
It's a fantastic point that you bring up COVID as well, because we were using what's called wastewater sequencing. So we were testing sewage to see geographical areas that had really high outbreaks of the virus. And we've actually shown that could be done for RSV, and it could be done very, very cheaply. And I don't know why we aren't. And I think we really need to lobby people. We need to get kind of governments and organizations on side that we could do that type of wastewater testing, so that parents know when there's an outbreak in an area. And I think giving parents that information to know cases are spiking in this part of this city, be careful, take extra precautions, maybe don't send your children to daycare if they're premature or if they have other conditions. And I think having that level of information would really just arm parents to be more prepared.
Absolutely.
I think for us we couldn't avoid it, because they were in the daycare from I think October till March. Every kid has a runny nose, so it's impossible. But I think the most important point is to raise awareness for parents, that they know that that RSV is existing, what this is, and how this can go with the kids, with preterm and also term babies. And just in our case, I know it. And we went to the pediatrician after a few days. They were sick. And I said, please test them to RSV. It was my sign. And I said that, and I wanted that to know, because as I have heard, it can so fast change. When they are sick one day, a little bit runny nose, at the other day, it can get worse very fast. So for me, it was very important to know if it is RSV, to know how to continue when they are sick. And I think this is a very important point to raise awareness for parents.
Maybe I can piggyback on, oh, sorry, Barbara, go for it.
A child is sick, I think it's mandatory to do the test. I don't know why you have to tell people, actually, because it is a difference. You know, as you said, the noses are always running from October to March, wherever you go. But it is a difference what they have. And it is mandatory to know, not only as a mother or as a father, but also obviously as a doctor. And I think if I just may add to the previous question you had, Annika, what would you do? What would you recommend to mothers or the people who got it? I think the thing with RSV is, and I had a healthy full-term baby, she was quite a stable one, but the thing with RSV is that, first of all, everyone can get it. And second, as Dina just said, it can change rapidly. So you have it like 2-3 days or even more days, and it seems okay, but all of a sudden it changes. And I think so what I would recommend is also get help early, because we did that. So we actually had a very, you know, it was difficult, but we had a nice, let's say we only stayed 3 days in the intensive unit, but get help early, because when you're at home, when this worsening happens and you all of a sudden see the blue lips and you get really, really scared, that's different. If you already have, you know, searched for help, you have information, maybe you're already in the hospital. So I would recommend to get help, you know, even if it seems only.
Okay, I think you're breaking up a little bit there, but I'll continue with the next question, because what I was wondering is also in general, we're discussing a lot things that could be done better and things that should be implemented also on a policy level. So when it comes to education and prevention, are there any best practice examples that come to mind? Again, maybe Lindsay, from the sort of academic scientific perspective, maybe you can start us off. What would that look like? Do you know of a case that you can share?
Well, I'm not sure about case studies to point after, because I think there's a lot of work to do in infectious diseases in general in terms of awareness, particularly for infections that infect young children. I think parents should be armed with more information, regardless of whether or not their child has the disease at the time. I think you need to pre-arm and pre-warn parents. So as both Dina and Barbara have said, they know what to look for, they know what to look out for. In terms of the science around prevention, I think highlighting things that are available, so things like the newly licensed nirsevimab, the monoclonal antibody treatment, making sure parents know that that is available so that they can ask for it if they're concerned. They can inquire about that with doctors. Knowing that there is a vaccine now available that's given during pregnancy, we certainly need a lot of public health messaging around that and just showing the importance of that. And I think the figures around the vaccination during pregnancy are fantastic. It's 81% effective at preventing severe infection within the first 90 days of life. And it's about 70% effective at preventing severe infection within the first 180 days of life. So that is those 6 months we talk about that are crucial. Parents need to know that. Parents need to know that information, and we need the public health messaging to be really strong around that.
Maybe I can piggyback onto that, because I think, yeah, you're making a strong point here for prevention and also, yeah, awareness raising. But of course, sort of the elephant in the room is that there's, in most countries, not enough doses of RSV prophylaxis. So how can we go about ensuring, yeah, equitable distribution of that what is available, especially when we know that healthy term infants, as in Barbara's case, can also have a very severe course of the disease. So we can't just say, that one patient group needs to get it first, because there's just so many. What would you recommend?
Yeah, that is really something that is fundamental to a lot of vaccine and prevention options for many diseases is kind of global equity and global availability. It is an issue, particularly for lower middle income countries. We need to make sure that they have access to vaccines, prophylaxis, monoclonal antibodies. I think we need to continue doing events like this, raising awareness. We need people like Dina and Barbara to speak up about their experiences, to lobby politicians, to make sure that the funding is available, to understand how much of an issue this is. And the power with that really lies in our politicians for various countries. And we need to make sure that they are aware of what RSV is, the burden it is, not only on the healthcare and the economy, but also on a personal level, and the burden on families and parents. And we need to keep pushing. We need to make sure that although there are now licensed vaccines, that this stays at the forefront of people's mind, because we will still see children that suffer from RSV disease. And we need to make sure that those prevention options are well funded and are available when needed.
All right, thank you. Before we close, I wanted to ask very briefly both Dina and Barbara, because you are sort of in the intersection of personal and professional angles with RSV. So first, Dina, I mean, you founded Frühchen Schweiz, so the parent organization Preemies Switzerland. And I was wondering, how has your experience with RSV shaped the mission of your organization?
Yeah, the mission changed now in October, since they decided that every newborn can receive it if they have enough prophylaxis. And we will raise awareness next year with a campaign for all the gynecologists, just to also inform all pregnant women about RSV during the pregnancy, because they also can be vaccinated during the pregnancy, and also about the possibility after the pregnancy for the vaccination for the kids when they are born, and also to raise awareness for all parents or new parents.
Fantastic, thank you. I think you're doing great work there. Then finally, Barbara, really briefly, sort of the same question. How has your personal experience with RSV informed your work in public health and neonatal care?
Yeah, we do the same, like Dina does, in a different way. We do policy work, and I think we got, a little bit far, because just today a press release by our health local health responsible, said that they would now try to make the vaccination available starting by November. It's a bit late, but better late than never. And it's what we did is actually talking economics, because as Lindsay just said, or as you said actually before, it costs a lot, the vaccination, and it's not available so much. But what costs more? Obviously, the intensive care unit for all the babies that need to be treated. So when you come with these calculations, you usually you bring up arguments that they listen to, and we do that. And we have to speak openly. We have some problems with our right-wing party here, with Meloni here in Italy. They do not invest in preventive medicine, especially not in vaccination. So we have some problems to face, and we face it with working on facts, information, and just showing them numbers, statistics, calculations. And I think at least on a regional level, we got a bit further.
Okay, fantastic. Thank you. I think we're coming to the end of today's session. Unfortunately, time went by really fast. I want to sincerely thank our incredible speakers, Dina Hedinger, Dr. Lindsay Broadbent, and Dr. Barbara Plack, for sharing their knowledge and experiences with us today. I think it's been an enlightening discussion, and we hope it has given you, our audience, a deeper understanding of RSV and the challenges families and healthcare providers face. I also want to thank all of you who tuned in today, whether live or watching later. Your engagement and questions have made this session engaging and very valuable. So in the coming days, we'll provide additional materials and resources related to today's topic, along with the full video of the session on the website you see on the screen below. We encourage you to check back for those updates, share them with your networks, and continue the conversation. So with that, thank you once again for being part of this important discussion, and we look forward to seeing you at our future events. Thank you and goodbye.
Bye.